Good morning and welcome. I'm Melissa Bondy, chairman of the Department of Epidemiology and Population Health here at Stanford, and also I'm the associate director of population sciences at the Stanford Cancer Institute. Immunotherapy is revolutionizing the treatment of lymphoma and many other cancers. And we're so glad that you can join us today in the discussion with cancer researcher and immunotherapy pioneer, Dr. Ronald Levy. Before we get started, I want to remind you that you can submit questions during the presentation using the QR code that's in your program and on the screen. Now it is my great pleasure to introduce Dr. Ronald Levy, the Ronald K. and Helen K. Summy Professor of Medicine, and he's also the director of the Lymphoma Program and associate director of Translational Science at the Stanford Cancer Institute. Dr. Levy was the first to successfully treat cancer with a monoclonal antibody, and he was involved in the development of an antibody-based drug called rituximab, which is routinely used to treat lymphoma. Widely credited with changing the paradigm for cancer treatment worldwide, Dr. Levy is currently conducting clinical trials of therapeutic vaccinations for cancer here at Stanford. He serves on the scientific advisory boards of numerous organizations. He's a member of both the National Academy of Medicine and the National Academy of Sciences, and he received the King Faisal International Prize in Medicine in 2009. Dr. Levy will spend the first 10 minutes sharing his groundbreaking work, explaining the fundamentals of immunotherapy, and then we will take your questions. So remember about the QR code to send your questions in so we can answer them for you. Dr. Levy, come on up so we can hear your presentation.
You stay here?
I'm going to go down.
Okay.
Great.
Good morning and welcome. Let me first apologize for looking down a lot because you can see the screen up here. I have the same screen down here, so I'll look at you once in a while, but mostly I'll look down here. Once in a while. So this is a story that goes back a number of years, and I want to explain about the immune system so you'll understand how to interpret the results, that amazing results we're getting today in the clinics. So I have a control here. So I want to explain about how the immune system works. This diagram shows the cells that are in our blood, circulating around in our blood and our body tissues. On the left, we have what's called B cells, and on the right, we have what's called T cells. There are billions of these cells all the time in our blood, turning over all the time. New ones are being born, old ones are dying out. And they have on their surface receptors that can recognize things. So on the B cell side, they have a receptor that becomes outside the cell in a form called an antibody. Those antibodies with Y-shaped structures recognize foreign invaders and glom onto them. You can think of them as smart Velcro. At their tips, they have sequences of proteins that recognize foreign invaders. On the right side, we have the T cells. They have receptors that recognize bad cells. Let's say the COVID virus comes into the body. It could be that green structure there. So if you have any antibodies against the COVID virus, it'll glom onto them and take it away. And if you have cells infected by the COVID virus, the T cells will kill those cells because the T cells have little packets of poison inside them that can kill target cells that you don't want to be there. So the critical point here is that we have billions of these things floating around, billions of different antibodies. Some are good and some are irrelevant. And if we can train the immune system by vaccinating, let's say the COVID vaccine, then we can have more of those antibodies against COVID and more of those T cells against COVID. And every B cell and every T cell only makes one antibody, slightly different one to the next. And we want to get the good ones and discard the bad ones. So you can imagine how the whole immune system evolved to fight foreign invaders like viruses and COVID and things like that. And the question is, what does it have to do with cancer? And the other question is, can we make it in a way to fight cancer? So the critical experiment that was done a number of years ago in England by two scientists, they figured out how to get the B cells that make the antibodies out of the body one at a time and make them live forever and grow outside the body and harvest the antibodies that they make forever. And therefore we call them monoclonal antibodies. They come from one clone of these B cells outside the body. And so I told you there are billions of these things. And once we get them one at a time, we have to figure out where the good ones are, if there are any useful ones. And that was the project that we first began more years ago than I care to admit. And so we discovered a target on lymphoma and leukemia cells. The name doesn't matter. And we discovered an antibody now called rituximab that you heard about. And this antibody recognizes this target on lymphoma and leukemia cells and some normal cells, a few normal B cells in the body as well. So we conducted clinical trials here at Stanford with this antibody that now is called rituximab. It was called something else at the time. It got a new name when it started to work. That's what usually happens. So I want to tell you about one of our first patients that we treated with this antibody. Wendy Harpham, here's her picture. And when she was a 36-year, she is a doctor, an internal medicine physician. When we met her, she was 36 years old. And she had been diagnosed in 1990 with follicular lymphoma. The summary is on the slide here. She had been treated with chemotherapy and it didn't stop working. And in 1993, she came and joined our clinical trial. She was one of the first patients that we ever treated with this antibody. And it worked in her. She had what's called a partial response, a PR on the right. Then over the years, one year after another, she was treated again and again and again, I think a total of 7 different times, sometimes with chemotherapy, sometimes on its own. And in 2007, she had her last treatment, and now she's 32 years from her original diagnosis, and she lived to see her grandchild being born. So it's a success story like that that led to the development of this drug, now called rituximab. And so, as the cartoonist of the day, Charles Schulz, told us, antibodies are wholesome, natural, without side effects. That's pretty much true. And it allows us to combine antibodies with other treatments that do have side effects. They don't add to the side effects of our other treatments. So we can make combinations of treatments based on this one antibody. So this is a story about finding a good antibody, having it forever, having it be a drug that works in the clinic, but it's a different antibody for each kind of cancer. We have one antibody called rituximab for lymphoma and leukemia. We have another antibody for breast cancer, and we have another antibody for colon cancer, et cetera, et cetera, et cetera. A different antibody, a different monoclonal antibody for every kind of cancer. I'm going to contrast this with what I'm going to tell you later, which is a more recent development, so keep that in mind. So back to the T cell side of the immune system. Everything I've told you about B cells is true for T cells, except they kill in a different way. They kill the invader in a different way. They see an infected target cell and eliminate it. So this scientist in Israel, friend of ours, turns out, working in Israel, decided if I take the Velcro part of an antibody and make the gene and stitch it together with the receptor of a T cell and make a chimeric antigen receptor called CAR, chimeric antigen receptor, I can put these genes into T cells and make them kill the target that I want them to kill, that the Velcro guides them to the right target to kill. So these are called CAR T cells now, and they kill leukemia and lymphoma really well. So the whole idea is shown here. The T cell gets the CAR, it finds the tumor, it goes to work, and destroys the tumor in the process of recognizing it, releasing the packets of poison that it knows how to release at the right time. So this is a treatment that's highly customized for each person. This diagram shows how it works. You take the blood out of the patient, and you get the T cells out of the blood. Tricky technology. Then you have to grow those T cells outside the body, and then you have to put the gene for the chimeric receptor into these T cells. And then you have to infuse those cells in the bloodstream back into the patient. Very customized, very expensive, time-consuming, and we wouldn't be doing it if it didn't work. So let me show you how it does work. This is an example of a PET scan of a person shown on the left, showing all those black blobs in his body, most of which are the lymphoma growing in his body after he stopped responding to all those treatments that are shown on the far left of the slide. And after the treatment with the CAR T cells made just for him from his blood, engineering those T cells. You have the scan on the right. Everything you see on the scan on the right is normal. The brain, the heart, the kidneys, and the bladder. But all those other tumors are gone. This is miraculous. This is somebody who clearly would have died of his lymphoma if he didn't get this treatment. More personalized is this. This is the famous patient, Emily Whitehead, who was one of the first patients with leukemia ever treated by CAR T cells in Philadelphia. And she her leukemia was very advanced and had failed all the usual treatments. And she got a customized CAR T cell made for her to target her tumor. And the picture on the left is her free of her leukemia 2 years later. At about that time, she met the then president of the United States, who congratulated her, Barack Obama. And the picture on the right, she's now 9 years cancer-free, probably cured of her leukemia with these CAR T cells. Very impressive, very expensive, very hard, but well worth doing. So everything I've told you so far is about going after the tumor cell, engineering that Velcro, that tip of the antibody, to recognize the target that's on the tumor cell, or making a CAR T cell out of an antibody to recognize directly how to recognize the tumor and how to kill it. The big paradigm shift that's happened just over the last few years is shown on the right of this slide. Scientists working all over the world have discovered that you can target, rather than targeting the cancer cell, you can target the immune system. Take the brakes off the immune system and let it do the job on its own. These two scientists, one working in the United States on the left and one working in Japan, got the Nobel Prize for this discovery that has really changed the way we treat cancer every day in the clinic now. What they discovered is diagrammed here. Don't bother with the details for now. What they discovered is the tumor cell and the T cell, although the tumor cell can be recognized by the T cell, is putting out signals that say, don't look at me, ignore me, don't kill me. And these signals can be blocked with a monoclonal antibody that talks to the T cell and defeats these signals and takes the brakes off, let the T cell do its job and kill the cancer cell on its own. This is an amazing discovery, and this has really changed the way we treat cancer every day in the clinic. And here's an example of one of the first patients with melanoma, a malignant disease, in an X-ray showed on the right of the slide in the upper panel, with the arrows pointing to all those abnormal tumors growing in the chest of the person. And on the lower part of the slide of the X-ray showing after treatment, disappearance of all those malignant tumor cells in his body. And on the left part of the slide is shown a graph where every line is a different patient, and whether the line is going up, the cancer is growing, and then if the lines are going down, the cancer is shrinking. Look at all those lines that are going down. And this is one antibody, in this case, two of these antibodies combined together, treating this previously untreatable malignant disease. It clearly would have killed the patient if they hadn't had this treatment. So now we have one antibody that talks to the immune system, that takes the brakes off the immune system. Everyone has an immune system, no matter what kind of cancer they have. We have Hodgkin's disease, melanoma, kidney cancer, bladder cancer, the whole list here. All these kinds of cancer are now being treated with this one antibody that takes the brakes off the immune system, let it do its job. So that's an amazing success. It's transformed the way we treat patients every day in the clinic with all kinds of cancer. So now with every success, we have to look at why it doesn't work all the time, because it doesn't work all of the time. Some patients respond and some patients don't. Of course, the tumor needs to have a target for the immune system to recognize. And the immune system has to be ready to go. If you take the brakes off the immune system, it can't do anything if it doesn't have the right receptors, the right T cell receptors. Not everyone has that immune system ready to go. Some cancers respond and some do not. Melanoma, but not brain cancer. Stomach cancer, but not pancreas cancer. Bladder cancer, but not prostate cancer. Hodgkin's disease, not lymphoma. So there are some big puzzles for us to figure out. And people all over the world are working on these questions right now as we speak, including a lot of us here at Stanford. Also, as I've implied, these therapies are not cheap, particularly the customized ones where we have to make new cells for every person, customized for that person. So we have to figure out how to make this cost effective and reduce the cost. And I didn't talk about the side effects of all these treatments. There are some side effects. Maybe we can talk about them in the questions and answers. And we're working on how to reduce the side effects. So where are we now in 2022? Using the immune system to treat cancer. We have monoclonal antibodies, a different drug for every kind of cancer. And they work, and millions of people all over the world have received these monoclonal antibodies by now. We have antibodies against this, taking the brakes off the immune system. One antibody for lots of different kinds of cancers. Used in lots of different people already. And we have engineering these T cells, these CAR T cells from the body, getting the right receptors into them so they know how to recognize the cancer cells and infusing them back into the person in a customized approach. So that's where we are today. Where do we want to be in the future? Obviously, we want to do better. And so this diagram kind of summarizes, in theory, where we are and where we'd like to be. This is a curve showing the survival of people with cancer over time. And the arrows on the left, the purple versus blue, drugs are approved by the FDA now based on extending life at the average person. But in green, we have some of these curing therapies, some of these antibody therapies and some of our targeted therapies and some of our immune therapies that I described that can actually cure some of the people in the green line. Where we want to be is up on the red line. And where we think we're going to do to get there is combine these treatments and discover new targets and train the immune system even better in the future. Now, when I show this slide to some of my colleagues, they look at the red curve and they said, I haven't been aggressive enough. 80% is not good enough. We want everybody to get cured of cancer. And so that's what me and my colleagues, not only here at Stanford, but all over the world, are engaged full-time, or more than full-time in doing. So thank you very much for your attention. We'll have some questions now.
Thank you so much, Dr. Levy, for sharing such valuable information. And we want to remind you for the last time, you can submit your questions using the QR code in your program, or I think it's on the program. So for those of you, or if those of you watching live stream, I think you have it also available. We also have a number of questions already, so let's get started. In your talk, Dr. Levy, you mentioned COVID, and since it's around us all the time, I think we should start with that, and I think we have a lot of questions about COVID. So I want to take a little bit of a deeper dive into that question. So how does the immunotherapy affect a person's susceptibility to COVID? And are people who are on immunotherapy for cancer considered immunosuppressed?
That's a really good question, and it depends on what we're doing to the immune system with the immunotherapy. In the example where we're taking the brakes off the immune system, that doesn't interfere with responding to COVID or COVID vaccines. In fact, you might wonder, maybe it makes them respond better because the immune system has no brakes. And we're looking at that question now. But in the therapies that suppress the immune system, like rituximab, that takes normal B cells out of the picture for a while, those patients are not responding to COVID with their immune system. They're immunosuppressed, and they don't respond to the vaccines, the COVID vaccines. For those people, we have monoclonal antibodies parked on the shelf against COVID that we can give to those people, supply them what they can't make, protect them from COVID infections. And what we know is that people who have rituximab don't respond to the vaccines for at least a year after their last treatment with rituximab. So during that time of treatment and all that time of next year, they need support from antibodies that we can give them from off the shelf. What we learned is that if we vaccinate people before we treat them with rituximab, they respond perfectly well to the vaccines, and they keep those responses during the therapy. So once we get the immune system trained, it's hard to eliminate that training, that memory that the immune system has, no matter what we do. So that's a complicated answer to a very interesting question.
So what should they do? So patients who are on immunotherapy, should they be tested, their antibody levels, so that you know what their levels are, so then that you could vaccinate them again, or boost them again? What would you recommend to your patients? And also,
yes,
being around their family members, so or not being around people that they think they could be exposed to? What do you recommend to your patients?
Until people have antibodies against COVID, either that they made on their own or that we give them from the pharmacy, they're susceptible to getting COVID. And they should not be around family members who are exposed to COVID. They should be masking, keeping social distancing. And we can measure the antibodies that they make. It's a standard test that we do in the laboratory here and other places. So we can measure this and tell them, yes, you have antibodies, you responded to the vaccine, you're lucky, you're protected, and you should be boosted to get even more antibodies. Even if you haven't made them before, maybe you should get boosted and try again. And we can know whether the boosting works or the vaccines work by measuring the antibodies in their blood. If they don't make them and don't have them, we can give them and protect them.
So we know boosting is important, and we also
Yes.
know for their family members that they should be vaccinated and boosted to help protect their family members that are immunocompromised.
The best way to protect an immunocompromised person is to vaccinate everyone they come in contact with around them, so they won't be exposed to people who are likely to have the virus.
Great. So we have a really great question that came from the audience, and they asked, can the antibodies and T cells cross the blood-brain barrier?
This is a great question, and it's not one that we planned to answer before, but it's one that we're really interested in. It turns out that the T cells, and sometimes even the antibodies, can get into the brain. We know the T cells, for sure, get into the brain and can kill cancer in the brain. I'm talking about lymphoma that goes to the brain. I told you on that slide that brain cancer that starts in the brain, these treatments haven't yet worked on brain cancer. But lymphoma or other tumors that go into the brain, those T cells can chase after them, get in there and kill them in the brain.
So Health Matters is an event for the entire community. We know that many individuals face challenges with access to care. Can you comment on what is being done here at Stanford to make treatments such as immunotherapy available to everyone who needs them?
Yes, this is a really important question, and we face it every day in the clinic. We have a healthcare system based on insurance, and insurance has restrictions on where people can go and be covered. Not everybody can come to wherever they want to go and be covered by their insurance. But we have clinical trials that we're testing all these new ideas. And when people are on a clinical trial, the trial covers the cost of the care. So our goal here is to make it cost neutral for anyone who wants to come here and be part of our clinical trials. So that's a complicated answer to a political question, but it's something we face every day in talking to people in the clinic.
So maybe that's why we need universal health insurance?
Well, I won't
Don't
get
go
into
there.
politics. It's hard enough to talk about the immune system.
We know our community is really concerned about some of these issues related to
Yeah.
financial
We as
toxicity.
scientists think that it's a triumph if we can solve the problem, and then we have to figure out how to get people access to the solutions.
That's right.
And that's the next challenge after that. We've seen that with COVID vaccines, where not everybody wants them, even though everybody can get them for free, not everybody will step up and do it. So it's a huge challenge to first solve the problem if we can, and then make it available to people and get people to get access to it.
That's right. So somebody asked a question about their about immunotherapy and for particular cancers, and their father wants to enroll in a clinical trial at Stanford, or this could be for anybody who wants to enroll. What do they do, and how do they find out about particular trials?
Yeah, great question. We have a national database called clinicaltrials.gov. That's the URL. You type that in your browser, clinicaltrials.gov, and you get a listing of all the clinical trials going all over the United States, including Stanford. Not only immunotherapy trials, but drug trials and other kinds of treatment trials. And then at Stanford, in particular, we have a Cancer Institute website. So Stanford Cancer Center, Stanford Cancer Institute, put that in your browser, up will come the choice for clinical trials. Then you see all the listings of all the clinical trials going on right here at Stanford. And you can know who to contact, know whether you qualify or not, and know some information about what the trial actually is testing.
Well, we've talked so much about personalized care and so many things about immunotherapy, and people ask about how they get their father on trials. How do we know if a person's a good candidate for immunotherapy, and if they have comorbidities or other issues or their age or so many kinds of things that people come to the clinic and they want to be on some of these trials? And how do we know whether they're a good candidate for these and whether or not they're going to be effective?
So I told on the slide, some people respond to immunotherapy, various ones I described, some people don't. And I said on the slide, the immune system needs to be trained, has to be ready to go. Not everybody's immune system is in that shape. There needs to be a target on the tumor cell, and we're starting to learn about the targets that are in play and how many shots on goal there are in anybody's tumor, how many targets they might have, based on the genes in the tumor cell and the mutations in those genes. So we're getting pretty good at predicting who's likely to respond. But if you have a treatment that doesn't have many side effects, not much to be lost. Go ahead and try anyway. And more we're trying no matter what we measure in advance. But there are side effects, and I didn't talk much about the side effects. If you take the brakes off the immune system, it's not going to only fight cancer. The immune system can fight the normal tissues in your body. And so we have side effects called autoimmune side effects. And sometimes we have to stop the treatment based on these side effects, but we don't know who's going to get these side effects until we try. So it's try as you go, adapt to what you see, and hope for the best.
It's always a problem, isn't it? And
Yes.
it's trial and error, and that's the practice of medicine. That's why we call it the practice of medicine. So at what stage of cancer is immunotherapy effective? Can it be done at any time? Is it ever too late to start immunotherapy? What do you think about that?
Well, all new treatments start at the end, after other treatments have stopped working, and they're tested on people who might benefit from it nevertheless. And then once they show promise and start to work, they get moved up toward the front. And we have some of these treatments now being used even before the initial surgery for cancer to try to reduce the size of the cancer, make the surgery easier. So there's every stage along the way where immunotherapy is being tested depending on which kind of cancer and which situation the patient is in. I would say that it's never too late to try, but people have to be able to know about the side effects that might happen, be able to tolerate, if they should happen, those side effects. So I think it's a constantly changing answer to this question about when's the right time, depending on what you've shown already can work.
Great answer. Thank you for that. So here's a question again from the audience, and it's not oncology related, but it's related to immunotherapy. So somebody asked a question: do you think we can one day reprogram T cells for MS treatment? What do you think about that?
So I once gave a talk to an audience and said, we're working on cancer, but would you be disappointed if we solved multiple sclerosis? And of course they said, no, they wouldn't be disappointed. It turns out that multiple sclerosis is the immune system attacking the brain and tapping the nerves. And we can dial down the immune system. In fact, rituximab, we didn't predict this in advance, rituximab or antibodies, monoclonal antibodies like rituximab, are very effective in treating multiple sclerosis and not making it go away entirely, but keeping the lid on and dialing down the immune system that attacks the nerves. And so that's a clue to the fact that the answer to this question is yes. In the future, I think we will be able to kill multiple sclerosis. When we figure out which T cells are in play, the antibodies are doing one part of the job, the T cells are doing the other part of the job, as I explained. Now that you're all experts in the arms of the immune system that I talked about in the beginning, you can imagine how we can deal with the right antibodies and the wrong T cells and devise therapies that dial down the immune system rather than rev it up. What you wouldn't want to do is give a multiple sclerosis patient a checkpoint antibody that unleashes the immune system. That's likely to make their multiple sclerosis worse. So in the prior question of who's a candidate for immunotherapy of cancer, to take the brakes off the immune system, if they had multiple sclerosis, they would not be a good choice for doing that treatment because you're likely to make that disease worse.
Great answer. So pancreatic and ovarian cancers are notoriously lethal. Is there hope that immunotherapy could be able to treat those cancers in the future?
Yes, there is hope, but so far we haven't solved the problem of pancreatic cancer. We're far from it. And it's ironic because to talk about shots on goal, pancreatic cancer has a lot of mutations in the tumor cells. There should be a lot of opportunities for targeting pancreatic cancer, and yet none of the therapies based on the immune system have worked so far in pancreatic cancer. In fact, not very many therapies other than surgery work on pancreatic cancer. So that's a big vista, and we have a program project here at Stanford just to work on pancreatic cancer. I hope that, that I'll be able to see the day when we're able to successfully treat pancreatic cancer. Ovarian cancer, we're a little more successful. A lot of the chemotherapies work in ovarian cancer. And now we're starting to get targeted therapies that target the pathways inside the tumor cell. Not immunotherapies yet, but targeted therapies. Small molecules that are like pills that you take orally that deliver a signal, turn off the signals in the ovarian cancer. So that's looking promising now. We hope that the immunotherapies will also one day attack ovarian cancer.
I think what's so important that you mentioned that people always ask me, I'm an epidemiologist, so is there a cure for cancer? Is that people don't understand that every cancer is different. And I think you've brought that out with immunotherapies and targeted treatments and things like that, that it makes it so difficult that not every cancer is the same and not every treatment's the same and not every response is the same. And so it's just really difficult that, when people think that when you have cancer that one treatment is the same for everybody, and it's not. And I think that you've brought that out with what you've said, and I think that's important. So here's a question about whether or not immunotherapy can be used for primary therapy, and I think you've already mentioned a lot of that, especially with neoadjuvant treatment and other types of things, or is it used in combination with other therapies, and if so, which ones?
Yes, all of the above. So in combination, as I said, where that red curve was not high enough, it should go to 100% in our future. Just recently, we heard about the checkpoint blockade antibody that I talked about, the one size fits all, take the brakes off the immune system for lung cancer before the surgeon operates on the tumor, to give the patients the checkpoint antibody, get the immune system working, and then remove the cancer, leaving behind an immune system trained to go after any other cancer cells in the body that the surgeon couldn't remove. A big success, and it'll change the way we treat lung cancer in the future. Just reported 2 weeks ago in our main journal. Very excited about that.
So here's a question about quality of life, and I think that's really important because as somebody's taking treatment, the quality of their life is extremely important. And we talked about risks and benefits, and we talked about how people tolerate treatments and things like that. And so can you elaborate a little bit more on the quality of life during and after immunotherapy? And some people have to take some immunotherapeutic agents for their entire life. And maybe we can talk a little bit about that and what effect that has on people's treatment and quality of life.
Yeah, that's a really important question. And it, again, depends on which cancer, which treatment, which combinations of therapies that we're needing to use to get best control we can of the cancer. There's always a trade-off between the good effects and the bad effects. And we want that ratio of good effects to be much higher than the bad effects. Sometimes we have to stop the treatments for the bad effects, the side effects. Interestingly enough, for those take the brakes off the immune system treatments, when they have bad effects, autoimmune disease effects, forcing us to stop the treatment, it seems that the good effects still persist in those people. Maybe the bad effects are kind of a barometer of how well it's actually working in the first place, how well it's working against the cancer in the first place. So we can get rid of the side effects by stopping. The good effects against the cancer can persist and go on. So that's really hopeful. But it's always very personalized to each person, each situation, and a trade-off between risk and benefit, good and bad effects.
So, Dr. Levy, you were a medical student here at Stanford and up until 1969, and then you joined the faculty in 1975. Over your long career in medicine, you've had some incredible breakthroughs, and then you've witnessed so many things in your career, and you've been involved in so many types of observing so many types of successes and treatments, and you've done so many incredible things. What do you think is going to be the next big discovery?
Yes, I've been here for a long time. That building over there was the only building when I was a medical student. Every other building you see around here is since I was a medical student here at Stanford. I've seen incredible growth in our field, but I've seen incredible successes that we couldn't have counted on before we started so many years ago. So the past is no guarantee of the future, as they say in the stock market, but I think that the past is a guarantee of the future with the smart people we have continually coming through and wanting to make the next breakthroughs. So I'm very encouraged every day coming to work, seeing the progress we've made, seeing the people living longer and being cured, and hoping that we can, make that better. I have to say that so many years ago, the first day I stared down the barrel of a microscope and saw that hybridoma, we call it, that antibody-producing clone cell pumping out those antibodies, shining back at me, I saw this whole future in front of me. It opened up everything that we've talked about. And I'd like to at the risk of embarrassing someone, I'd like to introduce you to Maureen O'Hara. Maureen, can you stand up? Maureen is now retired. She was the nurse who treated those original patients here at Stanford so many years ago, and is one of the heroes of the story. So thank you, Maureen, for being here and recounting some of the stories that we have that we remember together.
Thanks for being here. I know when Dr. Levy saw you, he was really pleased to know that so many of the patients that you were part of all of those patients with him.
Don't calculate the number.
I wasn't going to. So there have been many different types of leukemias. Does immunotherapy work for all leukemias or just specific types?
So far, just specific types. Leukemias from the lymphocytes are the targets that have worked. So far, leukemias from the myeloid, AML it's called, these immunotherapies haven't yet worked because, again, we haven't found the right targets, and we haven't found the right antibodies, and we haven't found the right T cells to go after AML, so-called. But for ALL, like the young girl that I showed the picture of, or for lymphoma, like the physician that I showed the picture of, the leukemias and lymphomas coming from the lymphocytes, those are the ones that we're succeeding on so far.
So when do you think there's going to be an effective cancer vaccine? Do you think it will be a reality?
This is what I work on now. Our lab is working on cancer vaccines, but unlike the COVID situation, where we know what the COVID is, we know what the target is, we can make a vaccine to prevent people from, train their immune system, make them able to ward it off should they ever get exposed to it. With cancer, we don't know which kind of cancer people are going to get. We don't know when they get the cancer, which targets they have in their cancer cells. So what we're working on is a vaccine after the fact, after people already have their cancer, discovering what their targets are and making vaccines to train the immune system against their targets in a more customized way. Whether we can make that work, it works in the mice so far, but a lot of things work in mice that have not yet worked in people. So that's where we are with that idea. There is one situation where we do have a vaccine to prevent cancer, and that's where we have a virus causing cervical cancer, the HPV virus. And we can vaccinate, this is a sexually transmitted virus. We can vaccinate boys and girls before they're sexually active, so they don't get the virus ever, and then in the future life, they won't get the cancer ever. So that's a demonstration that if we know what the target is, we can train the immune system and ward off cancer once we're able to discover the right targets. So that's a combined, like all the answers, they were sort of combined, and it all depends. And that's why we have so many people working on the problem. I gave you examples from people working all over the world, Israel, Japan, Texas is a foreign country, I know. That's where the Nobel Prize winner works. And even Philadelphia. So with those examples, you can see this is a worldwide enterprise. There are no secrets among us. whenever we have a success, we tell everybody about it and make things happen together. So that's the last thing I have to say, I think.
That was great. So I totally agree about the HPV vaccine, and it's now part of what we hope every 11 to 18-year-old will have as part of their regular vaccination program. And so many people don't always buy into it, like they don't buy into the COVID vaccine, but it's really important because it does prevent cancers in the future.
Again, another example of solving a problem and then getting it
Exactly.
to the people.
Exactly. It's
To the
there
people.
and available, and people should be taking it. So our last question, and I think this is a question we hear all the time, and I think you probably have answered this already, but we'll ask it one last time. Based on these new treatments, are we winning the war on cancer yet?
Well, if I introduce you to people who have been cured, the answer they would give you is yes. And we just need more of them, that's all. So we're still engaged in this war, and I use a lot of war analogies like targeting and killing, but that's exactly what we're doing. And I think that we're getting more and more tools to do more and more successful treatments and getting that red curve not only up to 80%, but hopefully 100%. That's where we are.
And I think working together and doing the things that we're doing as teams, and that hopefully we will be winning this war on cancer, but maybe it's going to be, as we say, a chronic disease in the future, and we still will have cancer, but maybe we will win and people will become having cancer as chronic diseases, not as not having it at all, hopefully. So Dr. Levy, thank you so much for sharing your insights and research with us. And thank you to all of those who submitted questions. And we weren't able to get to all of your questions, but for those of you who are here in person, Dr. Levy will be available over by the tent, and he'll be available for a short time to answer some of your questions. So we hope you will stay for the next talk called Pain, Pleasure, and Dopamine with Dr. Anna Lemke, and thanks of you who have been here with us today.